this is a discussion I think that actually bleeds into more advanced metastatic disease. Trying to think of how it is in your practice that you judge disease burden and how that kind of sets you up in thinking about targeted therapy approaches, immunotherapy approaches. Who are the patients who quote unquote need a response? It's a phrase that breast cancer physicians have used for years when thinking about combination chemo versus single agent chemo. So I suppose we have a little bit of that emerging in melanoma as well.
I was going to say it's fascinating that you said, treatment of choice would be the targeted therapy. I mean, it really rams home the concept that in the neoadjuvant setting, you're looking for good response, basically.
Fast response, good and fast.
Fast and good and deep, and that is the advantage with targeted therapies. However, it's the longevity that becomes the issue, but it really shows the issues we're going to be talking about in a minute with immunotherapies where primary resistance is an issue versus targeted therapies where acquired resistance is an issue. And when you've got it in the neoadjuvant setting where you've got a patient and you need quick reduction, you don't worry so much about the acquired resistance. You just want to get the parameters and get the whole thing out easily.
But even, again, so include 3 liver metastases and a couple lung nodules where surgery is not at play, but you still have, as you say, sort of psychologically impacting, if not symptomatic, superficial or palpable lesion. Again, where does that point you in terms of thinking about optimal targeted therapy strategy, mostly for the BRAF mutant population, of course, versus optimal immunotherapy strategy?
Oh, this is definitely an area that's evolving. I think our prior paradigm previously had been high volume disease you want to go after with targeted therapy to reduce it because it might be symptomatic, and that immunotherapy was really for low volume disease. And I think our recent data is starting to say that at least there's equipoise and perhaps it's the reverse. Recent data from colleagues here about with targeted therapy, those patients that really do the best appear to be those with lower volume disease, meaning less than 3 sites of disease, normal LDH, good performance status. Those previously had been the patients we wanted to put on immunotherapy clinical trials for melanoma, right? Yep. And it may be that those people drive the proportion of the benefit, of long-term benefit, to targeted therapy. Now, the question for an individual patient, absent a trial or something, is what do we do to help them the most? And I think that this is an area we're not totally clear on, but with higher bulky disease, if the patient doesn't need immediate response, I think there's growing data that suggests that combination immunotherapy in the high LDH population has the best potential for dramatic reduction with a long-term benefit. And so making this treatment choice right now is difficult, I think, and it's open to interpretation with different doctors. And I think it takes into account patient-level factors in terms of their preference for side effect profile, et cetera, as well as how you construct a treatment paradigm that's going to be the best for an individual patient over a long period of time. Because it may include an initial use of a targeted therapy in a transition or an upfront use of immunotherapy. And I have a case of mine treated with very high-risk bone-based brain metastases, got ipi/nivo, did very well, systemic CR, not CR in brain. And so, of course, because of the toxicity profile, she had to come off of ipi/nivo, but then transitioned quickly to BRAF targeted therapy with dabrafenib trametinib, and the patient's doing fantastic, right? And now this patient is basically CR throughout the body, back to work, looks great, and I think these kinds of approaches are going to be how we have to structure our treatment paradigm moving into the future.
Yeah, and this, of course, is the type of thing that's well beyond what trial evidence we have, so this is an important point. Jeff, it's one of the things I've found unsatisfying about the published literature on this point about sort of kinetics of response is the PD-1 CTLA-4 combo data, because the trials generally scan patients at 12 weeks, as was done with PD-1 monotherapy, as was done with CTLA-4 monotherapy. So in clinical practice, of course, you have patients who have palpable disease. You get a feel for how things are playing out almost week by week. So maybe for this audience, what's your feeling about the relative kinetics of response for ipi/nivo versus PD-1 mono?
Well, certainly with PD-1 alone, PD-1 drugs alone, you can see rapid responses, but I think most of us would agree as you accrue more and more patients on the combination therapy, both the responses happen quicker, they're a little, as we say, deeper, and then the toxicities are also coming on a little more quickly, a little more deeper, and there are multiple toxicities which would happen more often with the combination than with single agent therapy. So it's a trade-off, but the good news is for the high LDH, high tumor burden patient, they may do very well with combination ipilimumab and nivolumab. But vis-a-vis what Jason said, talking about mixing and matching. I like the idea in the BRAF mutated population of a brief burst of dabrafenib, trametinib, or Vemcobi, whatever you choose, stopping before you see adaptive resistance, before you begin to see resistance through the MAP kinase pathway, which Tony Rebus has nicely shown may also be one of the mechanisms by which you get immune resistance, and then coming in with IPI plus Nivo. I think that's a very clever approach, and I've yet to see anyone planning a trial of, say, brief course of targeted therapy followed by a longer course of immunotherapy versus a continuous targeted therapy plus the one immunotherapy agent, or just continuous targeted therapy alone.
No, this bridging concept targeted to immune for the BRAF mutant population, of course, has been on the table since vemurafenib and IPI were first approved 5 years ago. But yeah, the real evidence around these more powerful regimens is really yet to be demonstrated.
Yeah, it's dying for a randomized trial to either put it to rest or establish it as a potential new treatment modality.